Welcome to the Voices of the Collective. This is Dr. Zena Joseph. This is our guest for today's episode. Welcome, Zena.
Thank you for having me.
You're welcome. So for everybody who doesn't know who you are, what would you like to say about yourself? Who are you?
Who am I? Okay, well, I'm born and raised in Toronto, Canada. Graduated from the University of Toronto, went to St. George's University School of Medicine in Grenada for medical school, then went to University of Pittsburgh for residency, and then came to Long Island.
Oh, you had to say it like that?
Long Island. And now I live on Long Island.
Yes, good. You
for
got
the
it right.
past 14 years. See, I'm learning. I'm learning things.
How did you end
Yes.
up here on Long Island?
So for love, my husband is from Queens and Staten Island. And then when we got married, his parents moved out to Long Island. And when we had kids, we realized we needed help. So we moved to Long Island to be closer to them. So that's the story.
That's great. So he's always from Queens?
Born in India, came to Queens then when he was very young and then lived in Queens.
So for people meeting you for the first time, tell us a little bit about who you are and what led you to family medicine specifically.
So I've known since I was a child that I wanted to be a doctor.
Really? How young?
Probably diapers.
Wow. That's impressive.
Yeah. My parents may have had something to do with that.
How?
Pressure.
As soon as you were born, they were like, you have to become a
You're
doctor.
gonna be a doctor.
Ever since you were in diapers.
Yes. As far as I can remember.
Stereotypes are a time saver.
Yes, they are. Indeed, they are. Correct.
Why family medicine, though?
Family medicine, that was my first interaction with a doctor, right? My family doctor. So, and I liked my family doctor. So I just kind of grew with that. And I realized that I like to help all types of people. It doesn't matter if they're babies, if they're kids, if they're elderly. I like that broad scope. So that's why I chose family medicine. You never know what's coming through the door with family medicine. So it's exciting.
That is true.
Exciting.
That is true. Well, thank you for that. What was your experience like during medical school and residency?
Medical school was amazing because I went to medical school in the Caribbean. So I was studying on a beach and
Wow.
I created friendships with, people I'm still friends with. But it was a beautiful place. It was hard, don't get me wrong. There was a lot to learn and very long nights, but it was an amazing experience. And then residency was basically a continuation of that, albeit not on an island. It was in Pittsburgh, slightly different.
City, cold.
Steel City, right?
Yeah.
So, but I was part of a fantastic residency program at University of Pittsburgh. So we had a ton of residents. There was a lot of stress, but we were all in it together. So we were kind of like a team, like a family, which is ironic because it's family medicine, right?
No, in medical school, you do rotations in all different scopes.
Yes.
And you still wanted family medicine.
Yes. I did my family medicine rotations are about 4 weeks. I did my family medicine rotation actually in New Orleans.
Hey.
Yeah. So it's my favorite city in the States. So
Hey, shout out to New Orleans.
We doing?
To Nala.
To NOLA. And so when I was in New Orleans, that's when I really got a feel for how different medicine is practiced even within the same country.
Totally. There's a lot of things that are very different about specifically New Orleans.
Yes. And this was 2008. So it was only 3 years after Katrina. And even 3 years later, you could still see the effects of that, particularly in, poor neighborhoods, let's be honest. So,
Which is the majority of New Orleans.
That's what it is. So, Bourbon Street is one thing, but then what about the rest of it?
Mhm.
So that really kind of really reinforced the fact that people do need advocates, and they need
100%.
advocates who are smart and who are connected and who can speak and are respected in the community.
Yeah,
So,
over 20 years. It's been over 20 years since
has
Hurricane
been.
Katrina, and it's still devastated
correct.
area of our country and New Orleans, and they are a special breed. I have a lot of friends down there. I go down there
Yes.
for a week or two every fall.
Mhm.
And yeah, there's parts of it that just didn't recover. And
Nope.
advocacy is broad. There's so many areas in which people need advocacy, especially medicine. So how long did you spend down there?
I was there for about 5 weeks. Yeah.
That's very cool.
It was a good chunk of time. It was awesome. It was a great experience. So.
I love that city as well.
Yeah.
You spent years practicing in traditional medicine system.
Mhm.
What does that environment actually look like for most physicians day to day?
Hell. Yeah. That's hell. You want to picture hell? That's hell.
That's hell. Yeah.
Yeah. So traditional, I guess in the States, we should be more specific.
Drop a pin.
The emphasis is on making money. That's what it is, and
Yeah.
that's what it comes down to. So how do you make money? Well, you make money in two ways. Number one, you see more patients, or number two, you code for a higher level of complexity because that's how you get paid through insurance
Mm.
companies. The more complex the visit, the patient, the more money that you can bill for. But if they're not complex, you have to compensate by seeing more patients. So unfortunately, especially in the last 6 years, you've seen a lot of private equity groups kind of get into the field of medicine and they're buying up hospital systems and so forth. So when private equity comes into play, their bottom line is just money. It's really not about treating patients.
Or
So,
quality of care.
or quality of care for that matter.
Yeah.
It's just as much squeeze the insurance companies for as much as you can. And insurance companies aren't stupid. So there is a backlash towards that from them. Who gets caught in the middle? It's your doctors, your NPs, your PAs, and your patients. That's who really gets squeezed and who suffers. So,
What was your average day when you were practicing in that way?
so I usually had a between a 36-hour and a 40-hour work week. So that's patient facing care, right? That does not include charting, preparing for the next week's patients, studying, all this kind of stuff. That's all separate. So basically, my day would start immediately. So there would always be a patient waiting for me. Most patient visits were about 15 minutes. And I would see on an easy day, it'd probably be 20 patients a day. On a hard day, 26, 27. My record, I think, was 84 patients, but that in one day. But that was, at the height of COVID. So that was a bad day.
I mean, the burnout that
Yes.
I'm associating with that turnover
Hmm.
is really what I think the definition of burn and churn
Correct.
is.
Correct. It's assembly line medicine. That's all it is. So,
Assembly line medicine, which can't be good.
no, it's not good for anybody involved. Well, it's good for the insurance company.
Right, but I don't think the average person understands what a doctor or a PA or an NP is going through
Hmm.
when that's the model.
Right.
I think a lot of that is lost on the general person.
Yeah, and we're an easy scapegoat, right? If you've been waiting for 2 hours in a waiting room, you're going to yell at the first person you see, which will be your medical assistant, the nurse, or the doctor who comes in, because you don't know what's been going on in the background and what that person has been dealing with all day. So
Oh my god.
it's awful.
Yeah, hell, you said at the beginning of this.
Hell, yeah.
At what point did you start realizing that that traditional model of medicine wasn't aligned with the way that you wanted to care for your patients?
So this probably started around the time that we met. So that was about 2022.
Uh-huh, 2022.
20, I think it was 2022
Yeah, I think
when
you're
we
right.
met. So about 2, 3 years ago. Coming out of COVID, I thought things would get better and things just got worse. And I realized I cannot see myself doing this for the next 25 years. There's no way. It's not possible. So,
If you're saying that during COVID, you were seeing upwards to 80 people, and then it was only getting worse from
mm.
there, yeah, I can't imagine how you were getting up every day to go to work.
Yeah, it was a struggle. I mean, I just kept thinking about my family, but
Well, this kind of flows into the next question, which
mhm.
is, were there events that were coupling uh with your decision? Like, were there things that are standing out to you that you were thinking like, I can't do this, something has to change?
Yeah, so it would be so I have 3 children, young children, and one of the things is I would miss everything with regards to their school, right? So, especially as a working mom, you already feel that guilt. That's just part of motherhood. Add that on top of it. I realized that, this isn't worth it. It'd be a different story if it was appreciated and, I was being compensated appropriately. But to miss out on the events of the most important people in your lives, your family, and then go to work and not be appreciated, I just thought this is not the way that I pictured my life.
This isn't what
So
you got into medicine for.
no, and it's not about the money, but you should be compensated for the work that you do.
Yeah.
So just to give you an example, I made the same amount of money, I had the same salary in 2019 that I had in 2025. Actually, I was probably making less because I worked 4 more hours a week in 2025.
How did that happen?
It's just the
That
way
was
the
just
contract
yeah,
was.
the model in the
So,
contract
yeah. So,
was meant to pigeonhole you
you're right.
and
And yeah,
maximize as much as they could.
exactly. And inflation was going up, so my salary should have gone up, but
It didn't.
it didn't. That's not right.
You eventually made the decision to step away.
Mm.
And when you stepped away from that model and created your own practice, Safe Harbor Family Medicine, what inspired that transition?
I started to have intrusive thoughts. And I want to caveat this by saying I don't have a history of depression, okay? Not when I was young, not in my teenage years, not in residency, not when I was postpartum, never. That never happened. So I started having these thoughts of, what would happen if I just wasn't here? What would happen if I got into a car accident?
Yeah.
These thoughts started to go through my head. And as soon as that started, I said, Zena, something is wrong. This is not normal. And this is not depression. This is burnout. So,
That was around the time I think I met you.
yeah, I think I had come into we had an appointment one day, and I think I came into the room, the examination room, and you just saw it on my face. I didn't even say anything. I think you could just read the energy and read
Yeah.
my verbal cues.
I remember that day.
And you said, "Are you okay?" And something just kind of broke because it's not supposed to be that way. I'm supposed to be asking you, "Are you okay?" Not the other way around. So when I realized that, listen, this is also affecting my relationship with my patients, I said, there's, this cannot be it.
Yeah. So, just a little background for those who are listening. I'm a psychotherapist with, 15 plus years experience in reading people. And before that, I was a private investigator. So, I really have a pulse on people's energy shifts. And I do a lot of intuitive work in my sessions with clients. And when I saw Zena come into the office that day, into this little tiny box that I was waiting for her in, and also keep in mind, I had no GP up until this point. So, like, I, I spent a decade not having a family medicine practitioner assigned to me.
Mhm.
So it wasn't my first time meeting you, but it
No.
was in the same year of me going to her. And when I felt the heaviness that she walked into the room with, I did ask how you were. And I think what you said was, I almost drove into a tree this morning.
Yeah.
And I said, huh, we should talk. And I said it,
Yeah.
and I said, I
Yeah.
prefaced that with, I'm not a crazy person. I promise. I promise. Because with the line of work that we do, in all fairness, anything could walk through the door. So any level of mental illness could walk through the door
Mhm.
of either of our practices. And so I wanted to preface that I didn't come from a severe and persistent mental psych background. Personally, I worked in the field, but I wanted her to at least know that it was potentially safe for her to disclose to me what was happening so that I could give some guidance from a professional colleague standpoint and not necessarily a client dynamic. And I just wanted, from peer to peer, I wanted her to hear what I had to say based on what she was describing to me in that moment. But I remember leaving that appointment thinking, I have to connect with you.
Mm.
I just remember thinking, I have to connect with you. I don't know her really from a hole in the wall, but I was
Mhm.
like, I have to connect with you. I gave you my phone number, and I think you gave me yours. And I texted you saying, I swear I'm not crazy. I'll take you to coffee and you will come back in one piece.
Yeah. Yeah. That's pretty much, the how it started.
Yeah, it started.
Got
And
the
then
ball rolling
it got the
in a
ball. And
sense.
that was, yeah. And that was 2022. Now we're in 2026,
Mm.
and you're finally here at
Yes,
Limitless.
finally. Yeah.
So how does concierge
Good.
style or direct care model, how does that model allow you to practice the medicine differently than the traditional system you came up in?
So I feel like it's a very transparent and honest model. What it is the patient it pays me a monthly membership fee, and that fee is all inclusive. So it's a very simple process. It's an exchange. You give me a membership, whatever you call it,
Commitment.
commitment. And then you have access to me basically for the entire month. And that includes testing, that includes, any sort of counseling, forms, prior authorizations, anything that your traditional doctor would do, I would do for you. The way it differs is that because I am getting the money directly from you, I can keep my patient panel small. So, just for frame of reference, in the traditional model, most primary care doctors have between 2,500 and 3,000 patients in their panel. responsible for.
2,500 to
To
3,000 patients
3,000
in their panel.
in their panel. So
Okay.
that's who's assigned to you from the insurance companies,
Okay.
okay?
That's
You
a
may
lot
not
of people.
it's a lot of people. You may not necessarily see them, consistently, but that's who's on your panel. That's who you're responsible for. So in this type of model, I can kind of cut that down to about 200 patients.
Wow.
Other, what we call DPC, direct primary care practices, they range from maybe 50 patients to 600. It depends on how busy you want it to be. But my goal really is 200 patients. That allows me to have hour-long visits with
Yes,
patients.
that was the part I wanted you to share. We went
Exactly.
from 15 minutes rushing, not having enough time to even do the evaluation that I'm there
Correct.
for, to a whole hour.
Yes, to a whole hour. So, so even the way that traditional medicine, that encounter plays out in the real world is not correct medically. So, for example, when you come into a doctor's office in the traditional model, usually you have to wait. We've all accepted this. I don't know why, but we do. So you wait maybe for an hour. So then you get anxious, you get irritated, you walk into the exam room. What's the first thing that a medical assistant will do? She'll take your blood pressure, right?
Mhm. It's going to be elevated.
It's going to be elevated. That's not how you're supposed to check a blood pressure. The patient is supposed to be sitting quietly, with both feet on the floor for a minimum of 5 minutes. That's when you take a blood pressure, right? And it
Yeah.
should not be an electronic machine. It should be a manual blood pressure. But who has time for that, right?
Yeah.
So already you're starting the encounter incorrectly, and then it just goes downhill from there. With my model, you come in, you take your time, we chat, you sit for about 5 minutes. Then we talk about what are you here for? Then we start the physical exam. Then we talk about do we need lab work, prescriptions, imaging, whatever it is you need. It's not a rush visit. We can take our time with it. That is what traditional family medicine is supposed to be. So this is kind of, in a sense, a throwback to old school family medicine.
That's how I remember my
Yes.
visits with my pediatrician.
Yeah.
And it was, to me, as a little kid, I thought it was going to be an all day affair because I'm like, yes, we had wait times still, but then
Yes.
once you were in there, the family medicine group that we were with were brothers. And
Mhm.
so whoever we were going to sit with, I knew I was going to be there for at least 45
Yeah.
freaking minutes. And as a
Correct.
little kid, I was like, oh,
Yeah. Yeah. You take a
yeah,
lollipop.
yeah, or 20.
Or 20.
But that was how I recall it. And I was lucky
Correct.
enough with my kids that we had a pediatrician who was in practice for 47 years and took
Mhm.
everything very old school. So we had we were lucky in that sense. But
Mhm.
I know that from my own clients and people that my friends who have children and just in general have their own health conditions, it's not like that.
No, of course
Not
not.
like that.
Of course not. So,
Well, that's
yes.
great. So
Yeah.
what has changed for you personally now since creating this practice where you get to control the pace
Mhm.
and the relationships and care model is all under your design? So what's that like? How has that
Yeah.
changed
No
your life?
pressure. No, I'm kidding.
Tell me how that's changed your life.
Yeah. So, just like physically, I sleep better. I have more energy. I'm actually excited to come to work, which has never happened to me
How
before.
exciting. I love that.
Yeah. Yeah.
I
It's
love
a
when you come
beautiful
in.
place.
You guys can't see it on the camera here, but Zena wears really fancy and awesome shoes every day. I don't know if she can.
See,
You can. Oh, there we go.
yeah.
Yes, there it
The
is.
shoes have been, yes, a talking point.
It's exciting.
Yeah,
I
I
get to
like
see which
them.
one she brings in every day.
Exactly. So physically, it's definitely had an effect on me, and my patients have even noted that, right? So that's good. Second of all, I have a lot more time to advocate for patients. Here's a small example. So I had a patient who is a diabetic and is taking a GLP-1, the injectable.
Hmm.
So he needs it. It's medically indicated. He's a diabetic. We have all the documentation for it. So I tried to prescribe it recently for him, and automatically, we use the insurance to pay for meds and imaging and labs and things like that. So when I sent the prescription over, I got an immediate fax back saying, oh, this is not under their coverage, so they
Hmm.
can't get this. If you would like this, you would have to do an appeal. Okay, now I have the time to do the appeal. So I write up a nice appeal. By the way, I did not use AI or anything,
ChatGPT.
or ChatGPT or Gemini or Claude, whatever you want to call it. I did it all myself, did the appeal, faxed it over. Immediately, again, got a denial back. We've looked over everything. Yeah, right. And the patient still does not meet criteria. So I said, okay, Now I'm going to do what's called a peer-to-peer. A peer-to-peer is when a physician asks to speak to a physician who works for the insurance company, and then you kind of plead your case as to why the patient
And
needs
you highlight
this.
all the ways in which he does
Exactly.
meet
I
the
mean, and
markers.
he did. I'm not even lying about this. His A1C is elevated, and we had
Yeah.
done blood work and all this kind of stuff. And he had done great on the medication. So then, you make this appointment to have this conversation with this doctor. So the appeal was set up for a day or two. This peer-to-peer, excuse me, was set up for a day or two after I sent the original appeal in. So, and it's a specific time that that doctor is supposed to call you. So I cleared my schedule and I'm waiting for this doctor to call me. She didn't call. I said, okay. So then a couple hours later, I get a phone call from her and she says, oh my God, I'm sorry. I was doing this thing, whatever her reason was. Can we do the appeal now? The peer to peer now? I said, yeah, we can do it because I had time. I
Yeah.
wasn't seeing other patients. I wasn't rushing. I wasn't
That
completely
would have been
stressed out.
completely unheard of in your other.
It wouldn't have happened in
Yeah.
the other place. No one has a time for it. And the people who are, I guess, assigned to do the prior authorizations and the appeals, I hate to say it, but they're not usually doctors, right? They don't know the verbiage, the terminology, what needs to be in that prior authorization in the first place. I know those things because that's my job. So because of this, we were able to get the peer-to-peer approved. They approved the medication for about a year. I have to say that doctor was really, really nice. This is an example of something that
Normally would fall to the wayside or never happen.
it would have never happened. We would have
Right.
said, sorry, you have to pay out of pocket for it because we don't have the time to do
Right.
all this stuff.
And a couple other things that she's not mentioning is she actually has time to go to the bathroom now. She has
Yes.
time to eat
To
lunch.
eat. Yeah. Drink water.
Yeah. Which all these things she couldn't do in her other job. I
No.
would check in with her for the last 3 years. I would check in and say, did you have lunch today? She's like, nope, still working. I'll be here till 8 o'clock.
Right. So that's hypocritical as a doctor, right? Here I am telling patients you need to eat on time, you need to exercise, you need to drink a lot of water. I was not doing any of those things.
You couldn't.
I couldn't. I was a complete hypocrite. So I practice what I preach now.
Wow.
So if people start to give me, any sort of pushback, I say, hey, I do all these things. So
Yeah. That's you. We met while both navigating healthcare in different ways, and eventually you joined the ecosystem at Limitless Integrative Wellness. What about that collaboration felt aligned to you?
So number one, I believe that the future is female. And I really like the fact that everyone who is here is a woman who's trying to make a difference. They're not really doing it for the money. They're doing it because they believe in what they do. That honesty is what I really liked. So that kind of drew me to it and I felt very comfortable in it. It's also great to be able to collaborate, right? So if I have someone who, for example, I know needs a nutritionist, I'm like, where do I get a nutritionist from? I'm like, oh, it's a nutritionist who comes in, or someone who would really benefit from massage therapy. I have someone here. It's so easy. You know
Yeah,
what I mean? Like I give them a card or I walk them down the hall. I say,
right.
hey, meet blah, blah, blah. So that's,
And you do a little bit of psychiatry, but if
I
if
do.
there's like something that's in more depth, we have a concierge psychiatrist here as well.
There you go.
We have so
So
many different things.
yeah, we have a therapist. Even if we have what we call curbsiding in medicine. Curbsiding means you don't have an official consultation, but you can run something by someone who's in that field. It's
Yeah.
very easy. You don't have to really search for it.
And in all fairness, she's been coming to our events for 2 years, 3 years because I've been making her making her come. She's help. Yeah, what's the sign for
What's the yeah.
I was just gonna do the same thing. Yes, but yeah, just I think we're so lucky to have you here, and you've been such a great addition, and it's just fun to have people that you
Yeah.
can come out of your office and work. It's a passing and saying
Mhm.
hello, but still is better than what you were experiencing before, I'm
Right.
sure.
Right. There was no real collaboration. The old place.
Well, because I think people were operating in silos before, and
Yeah.
now
Yep.
we get to be in a group together,
Hmm.
which is exciting.
Yeah.
So the
Definitely.
future of healthcare, you said the future is female.
Yes. Future is female.
What do you think patients are really craving from healthcare right now that the traditional system can't offer?
So they are craving people who listen. That's the one complaint I keep hearing from my patients is, they didn't listen to me. It can be male or female, it doesn't matter. They just feel like the doctor who is with them is either facing the computer, typing away, asking the same questions over and over again because they didn't get the answer the first time. So patients don't like that. That is understandable. From
Yeah.
the doctor's point of view, they just don't have time, right?
Right.
They have to chart, they have to make sure that, the next patient is not wait is, again, burnout with that. So that's been the number one complaint from patients is people who don't listen.
So
Oh.
they're craving somebody who can listen.
Yes. And this model allows me to listen.
Yeah, you could do so much more with this model.
Correct.
If you could redesign healthcare for women and families from the ground up, what would it look like?
There would be more of an emphasis on prevention.
Oh,
Go figure.
imagine that.
Imagine that. So we take a reactionary approach to medicine. We wait till you get diabetes before we give you medications, right? So with me, if I could, design it myself, things like a gym membership, massage therapy, counseling, all of those things would be included as part of your preventive care, right? Because right now your mammogram is covered, your colonoscopy is covered, anything preventive is covered. Why can't those things be part of it?
Yeah.
Even if we talk about GLP-1s, for example, the patient has to have a diagnosis of diabetes really to get those medications approved. But why can't we do something beforehand so they don't become diabetics? We can prevent diabetes. Why
Yeah.
don't we cover those things?
Same reason why we don't make things that sustain time, right?
Correct.
Planned obsolescence.
Right. Exactly.
We're gonna
So
get canceled.
right.
We're totally getting canceled.
I don't care. I'll move. It's
You
fine.
can't move.
I am
You got
Canadian. I can move back.
That's true.
No, I'm not
Yeah.
going anywhere.
But yeah, you're right. There isn't a system that it's I mean, I think even some would argue it's built to keep you sick.
Yeah, that's something we hear all the time. I don't think doctors want to keep you sick. We really
No, not them.
don't.
I'm
But
thinking the system.
the
It's not
system,
you guys.
yeah. So it's sad, but that's how I would change it.
Outside of medicine, what are some things people might be surprised to learn about you?
I ran my first half marathon.
Yay!
I didn't die.
Nope, she didn't die.
That's good.
She's
Yep.
still Canadian.
I'm still Canadian. Yep. But I have dual citizenship now, so I can vote.
Hey,
How you doing?
how you doing?
What else? I play piano, I sing, I'm a chauffeur for my kids. So I
That
go
part doesn't
everywhere.
surprise me. The piano and the singing surprises me.
Yeah, I played for a long time.
How long?
I studied for about 10 years.
Wow,
Yeah.
that's awesome.
Yeah.
She also likes dance music, which I love as well.
So that's really why I joined the practice. So I said, if this person gets my weird niche kind of music.
I totally do.
Yeah. And for everyone out there, what is our niche thing?
Utopia, EDM.
That's right. From a particular decade.
Yes,
though.
from a particular decade.
So late 90s, 2000s.
Yes,
is
yeah.
what we're talking about.
Exactly, when it was good.
Correct.
Exactly. All right, perfect. So what do you do to recharge yourself after seeing patients?
So usually I'll go home. I try and get a monthly massage,
Very good.
self-care. I listen to our EDM
Mhm.
and
It's-
you gotta fist pump
Yeah,
it
fist
while
pump
you're
it.
doing it.
Night at the Roxbury.
That's more this, right?
Yeah.
So music, massage therapy. I play with my kids. I talk to friends. I socialize. I think that's also very important is to keep those kind of social networks kind of going. So, and I look at memes.
I mean, yeah, of course. If a physician listening right now feels burned out in the traditional system, what would you want them to know?
Call me.
Yeah, call us.
There are options.
There are
okay?
options.
There are many, many options. You don't have to stay in this kind of traditional model. They
And
will
she was
yeah.
scared to leave.
I was scared. I was terrified.
Yeah.
I don't know anything about
It wasn't an easy jump.
this. No, it wasn't.
I might have checked in multiple times in the last couple of years
Yes.
pushing this idea just because Zena's very gifted at what she does. She's a really personable person. She's funny. She's real. She's down to earth. We need more people like her in this field. The idea of her retiring and not doing this anymore was something I couldn't accept, especially coming from somebody who already had an issue with the healthcare system and found somebody that I could trust at a very vulnerable time of my own healing journey. So the thought of her struggling to this degree was something I just wasn't willing to let go of without helping address. So I think, yeah, the transition wasn't easy, but it definitely was in alignment for you.
Right.
And yeah, anybody else that's going through that.
Yeah. One thing that corporate America will try and make you feel is inadequate, right? They'll say, well, You don't know how to do this. You can't do this. We're the executives, we know how the business world works. And I just want other doctors to just remember you went to medical school and you went through residency, okay? If you can do that, you can do anything. And this is the modern age, right? Everything is Googleable. You have a ton of resources online. Doctors are always willing to help other doctors. So, at least the majority of them. Don't feel inadequate. Don't let them make you think that you can't do something. That idea is ridiculous. So we don't need more C-suite executives. We need more doctors, particularly primary care physicians. There is a way out, and there's lots of options, like I said. Definitely look into DPC, direct primary care, if you're a primary physician, and ask questions because we're willing to help. So,
Exactly, exactly. Well, thank you for joining me today.
thank you for having
It
me.
was a pleasure having you on the Voices of the Collective, and it's always fun.
Yeah,
It's always fun.
we're gonna put some EDM on.
We should. To connect with Dr. Zena Joseph and learn more about her concierge style practice, Safe Harbor Family Medicine, head to the links in our show notes. This is what modern collaborative healthcare looks like. Be sure to follow, subscribe, and share Voices of the Collective, and stay tuned for more conversations redefining wellness.